Today, we're diving into a condition that is, well, a real puzzle, one where the body's own defense system basically goes rogue. We're talking about multiple sclerosis.
Just think about this for a second. What if your own body declared war on your brain? I mean, the very system that's designed to protect you? What if it got confused and started attacking your brain and your spinal cord like they were the enemy? Well, for millions of people, that's not a what if. It's their reality. It's a condition called multiple sclerosis, or as you'll often hear it, MS. So let's get into what that really means.
So let's start with the basics of this mysterious attack.
Okay, so what is MS? At its absolute core, it's an autoimmune disease. Basically, your body's defense system gets its wires crossed and starts attacking healthy tissue it's supposed to protect. And in MS, the specific target is the central nervous system. You know, the brain and spinal cord, the body's entire command center.
And it's not just a random attack. The immune system has a very specific target, a substance called myelin. The best way to think about this is like an electrical wire. Your nerve fibers are the copper wire, and myelin, well, that's the plastic insulation wrapped around it. It makes sure signals fly down that nerve super fast and accurately. In MS, the immune system starts stripping away that insulation.
Yeah, so this attack on the myelin kicks off this whole cascade of events. It's really like a civil war happening inside the body.
It all happens in a few key stages. First, you get what's called demyelination. This is where inflammation creates these little areas of damage, or plaques. That damage then leads to axonal damage, so the wire itself gets hurt, and that can block the nerve signals completely. Now, the body is pretty amazing, and it tries to repair the damage through something called remyelination, but if the attack keeps happening over and over, you eventually get what's called gliosis, and that's basically permanent scarring that messes up the communication for good.
So, for a doctor to be sure it's MS, they can't just see one spot of damage. They have to prove this isn't a one-time thing. They're looking for two key pieces of evidence. The first is dissemination in space, which is just a fancy way of saying there's damage in different parts of the brain or spinal cord. The second is dissemination in time, which means they have to see evidence that these attacks happened at different points in time. And because this damage can pop up pretty much anywhere at any time, the experience of living with MS is just incredibly unpredictable for every single person.
This randomness is why the symptoms are all over the map. You know, if a sensory nerve gets hit, you might feel tingling or numbness. If it's a motor nerve, you could have weakness. And then there are these really specific, kind of strange signs, like Lermit's sign, which is a zapping, electric shock feeling down your spine when you bend your neck, or Uthoff's phenomenon, where symptoms just get worse when you get hot.
Okay, so even though the symptoms can be all over the place, the way the disease progresses usually falls into one of two main buckets. The vast majority of people, something like 90%, have what's called relapsing remitting MS. The other 10% or so have primary progressive MS.
So what's the difference, right? Well, relapsing remitting is exactly what it sounds like. You get these clear attacks, or relapses, where symptoms suddenly get worse. But then, they're followed by periods of recovery or remission where things get better. Primary progressive, on the other hand, doesn't really have those big flare-ups. It's more of a slow, steady decline right from the get-go.
So, with all this complexity, how on earth do doctors figure this out? It really is like putting together a puzzle.
The number one tool in their detective kit? It's the MRI, specifically a special kind called a gadolinium-enhanced MRI. That gadolinium is a contrast dye that basically makes any active inflammation light up so doctors can see these lesions with amazing clarity.
And when they look at that MRI, there's one really classic clue they're searching for. It's called Dawson's fingers. It's this very specific pattern where the lesions kind of point out from the center of the brain, almost like, well, like fingers. It's a huge telltale sign of MS.
But sometimes the MRI isn't the whole story. The next step is often a spinal tap to check the cerebral spinal fluid. And what they're looking for in there is the smoking gun, something called oligoclonal bands. Finding these specific proteins is a massive clue because it tells them the inflammation is coming from inside the central nervous system, not somewhere else in the body. And the final piece of the puzzle is making sure it's not something else. There are a couple of other conditions that can look a lot like MS, like NMOSD and MOGAD, but there are key differences. See, those other conditions have specific antibodies you can test for. MS doesn't. They also tend to cause really long lesions in the spinal cord, whereas MS lesions are usually shorter. And remember those oligoclonal bands? They're almost always missing in these other look-alike diseases. Okay, so once the diagnosis is certain, the big question is, what do we do about it?
And this is where the story gets really hopeful, because science has made some amazing progress. So if someone's having a full-blown relapse, the first thing you want to do is just put out the fire. You need to calm down that inflammation fast. And the go-to for that is a short course of high-dose IV steroids. It doesn't cure the damage, but it can make the attack shorter and less severe.
But that's just for the acute attacks. The real long-term game is about preventing them from happening in the first place. That's where disease-modifying therapies, or DMTs, come in. The classic first-line treatments, things like beta-interferon and glatiramer acetate, have been around for a long time. They're injectables that help dial down how often these relapses happen.
But we've come a long way since then. The next step up the ladder includes some really effective oral meds. You have drugs like fingolimod, which works by trapping some of those attacking immune cells so they can't get to the brain, and others like dimethyl fumarate, which kind of retunes the whole inflammatory response. And then you have the big guns, the highly effective therapies. We're talking about things like anti-CD20 antibodies. Ocrelizumab is a big one, which basically wipe out a specific type of immune cell that's causing trouble. Then there's natalizumab, which is incredibly powerful, but it has a catch. It comes with a risk of a very serious brain infection, so doctors are extremely careful and only use it for certain patients.
So let's just wrap this all up. What's the big picture? Multiple sclerosis is this incredibly complex attack by your own immune system on your brain and spinal cord. Doctors nail down the diagnosis by finding damage in different places and at different times. And while we don't have a cure yet, we have this huge and growing toolbox of therapies to fight back and manage the disease. And that really leaves us with the big question for the future, doesn't it? Science is moving so fast, we understand so much more now than we did even 10 years ago. So you have to wonder, are we getting closer to a day where we can not just manage MS, but actually stop it dead in its tracks? Maybe even reverse the damage? It's a hopeful thought to end on.